falls in this category, but it's not totally inclusive in this category. So hypertrophic cardiomyopathy just means anything where the muscle wall is thicker than it should be. And again, so just going from a basis of what we know from just medical terminology and what we know just physiologically with the heart, um, tell me what types of things we'd be looking at and for with hypertrophic cardiomyopathy. Just tell me a little bit about what you know about it.
Thickened walls.
Thickened walls, fundamental start, yes.
Would it be like
So go ahead.
the, the symptoms of like aortic stenosis essentially? Because
Could
there's
be
not
yes.
enough.
Yes. So part of that could be. Are all presentations of that going to have like an aortic stenosis? No, just one in particular. Okay. So thick walls. So what do you think we'll do in echo? What do you think our main objective is? Just knowing what we know now so far. Show me
Wall
the
thickness.
show me the walls. Measure the walls. Okay. If we get and if you can look at this picture, the pathology samples. If I've got thickened walls, what can you say probably about the chamber sizes?
Smaller.
Tiny. Yep. So typically the muscle space is going to encroach on the lumen space or the whole the fluid space. So it's going to encroach on that and therefore getting less. What do you think about diastolic function?
Oh, very decreased.
Yeah, so it very, very stiff. I mean, you think of, I don't know if many of you guys remember this, some of you might remember back in the 80s, like the bodybuilders were like the big thing. And they couldn't wear like normal jeans and stuff. They had to wear these baggy sweatpants type pants because their legs were too thick and nothing fit them. And the guys that they couldn't even touch their fingers together in front of them because their chest is so big and their arms. That was kind of a thing back in the 80s, maybe early 90s. And, but the muscle's the same way. If we've got this big, thick, bulky muscle, there's a lot of restrictions happen because of it. It's going to encroach on the space, but it's also now going to affect things like chordae tendineae, where dilated cardiomyopathy pulled them away from the valves. Now those chordae tendineae have to go around that big thick muscle to get to the valve. So again, it's being stretched by a different mechanism. So with dilated cardiomyopathy, what was one of the ways that you could diagnose dilated cardiomyopathy versus something else?
All four chambers were dilated for no reason.
Yes, and for no reason, just to expand on that means again that there's not other valvular damage type things going on. So same thing with hypertrophic cardiomyopathy. It's independent of other things like that that might have caused walls to be thick. Okay. So even though we may have some processes that sort of contribute to that thickening, there's a mild degree of thickening, which is like your hypertensive type patients versus a true hypertrophic cardiomyopathy type of thing. And I like these pictures because you can see that these are like super thick. They're not like a little thick, they're super thick. This is like a steak. Okay.
So is that little hole supposed to be the cross-section view of the heart?
Yeah, this is like, and I don't know exactly what level, but I'm presuming that this is actually at, close to the papillary muscle level, but this is like the residual hole. that's the lumen. At least from the apex to the mid portion. I'm not sure if we're higher than that, but that's, as you can see, this is significantly thick. If I was smoking some meat in my smoker, this almost looks like a smoke ring. But this smoke ring type of appearance right here, that's about what a normal heart should probably look like as far as thickness goes. The rest of this is, it's super thick. Now this is an extreme case, obviously. Okay, so again, generally speaking, well, characterized by increase in LV wall thickness and or infiltration of the myocardium. Okay, so it could be because of a muscle protein issue where it's they don't form correctly and stuff, and they cause these big bulky muscle cells, and or it could be due to infiltrative states where we get deposits of things inside the muscle causing a thickening also. Let me jump back to the image real quick here. So this is mentioning LV wall thickness, but I just want to show you here on that big thick chunk steak sized right, the cross section, what can you tell me about the right ventricular free wall on that one? Does that look thick too? Is it normal?
I mean, it looks thick. I
Yeah, in
can
this case, it's also definitely thick. Okay, so it's not always just LV; it can be both. And as this picture describes, you can have different variations of thickness in different places. So we have a concentric thickening, which would be that last picture, where it's equally thick all the way around. And then we can have regionally thick areas as well. Now, don't mistake that again for CAD, because coronary artery disease, we're going to have thinner walls in some segments because it was injured and scarred, and you're going to notice there a lack of thickening during contraction. Whereas these will still be contracting normally, but it might be thinner than those other big spots. Mike, go ahead.
So for the reason in that first picture that we saw, for the small RV, is that also because the LV is like infringing upon it, or is it just overall things are thick?
Yes, both could be true. Yeah, it could be because it's pressing in on it significantly, and or because they're both thick. And in this case, on that one on the right, those are definitely both thick. The other pictures of the right heart there, as you can see, the right ventricular free wall is actually pretty normal size on those other two samples. So yes, it could be affected both ways. So we have the normal heart here. We have a concentric thickening, which is fairly equally distributed through the whole muscle. And then we have regionally thickened ones, like in the obstructive type of disease. Well, this one's actually showing obstructive because it's coming there, but there's concentric, meaning all the way around. There's asymmetric is what we call it when we have an asymmetric septal hypertrophy, for example. The septum is super thick, but the posterior wall is relatively normal. Okay, so compared to each other, one's significantly more thick than the other. So that's kind of how we'll describe these. So our job as echo techs, fundamentally, as we go to do the echo, is show me all the pictures of the ventricles, both right and left, and show me and measure the thicknesses of those, relatively speaking. We'll also take note of the chamber sizes because that's going to be directly affected by it. And then, sort of a secondary thing from that is proving that there's no other cause of that happening, like an aortic stenosis or something like that. Okay, so so what does it mean to be thick? So what's our normal wall thickness? Do we know it to be?
Is it 6?
Yes, less than 6 is thin, so 6 is the minimum, to about what?
11?
Okay, it's about 6 to 9 on current standards. In my lab, we never considered it thick until it hit 11. So we had that sort of gray zone. That's so if it's 10, it's like you're not going to be like, oh man, they all of a sudden have hypertrophic cardiomyopathy. We didn't really call it hypertrophic cardiomyopathy or even just hypertensive or thick walls until it hit 11 or bigger. For true hypertrophic cardiomyopathy here, they're showing that it's got to be greater than or equal to 13. So we've got our mild thickening, which could be like from hypertensive disease, which is fairly common. And then it doesn't become truly into that hypertrophic cardiomyopathy range until it hits 13 or above. Okay. And again, those are general numbers. So that's taking into consideration all population types, men, women, different ethnicities, etc. Whereas the newer charts are showing differences between that for normal thicknesses and stuff like that. So there is some variability in that based on that patient specifically. Again, so this is 13 millimeters in the absence of significant hypertension or blood pressure or other factors that cause pressure overload or infiltrative state. So again, the pressure overload would come from something like, an aortic stenosis or a mitral stenosis or just fundamental diastolic dysfunction that preceded this. And then infiltrated states are things like amyloidosis or sarcoidosis, which actually get deposits and stuff inside the tissue. Prevalence of true hypertrophic cardiomyopathy is 1 in 500, so not super rare, but not super common either. 1 in 500 is a pretty decent amount of population. More than 400 distinct genetic mutations that can result in an alteration of troponin and myoglobin. So the true through, again, hypertrophic cardiomyopathy is caused by mostly those two proteins in the muscle itself. And again, there's 400 possible genetic mutations that could contribute to that. So it's not like we're going to narrow down to one specific one necessarily based on echo. But giving the overall disease state, generally speaking, will still help the doctor to narrow it down. If they need to know what those genetic mutations are, they can do genetic tests to prove specifically. Nancy, go ahead.
This version of the book says that there's more than 1,500 distinct genetic mutations reported.
So even more. So I don't know, about 5 years, I think is all it was from that 8th edition to the 9th edition of Feigenbaum, or 7th to 8th, I think it was. Yeah, so we are discovering more and more stuff. So yeah, that changes. Okay, so all forms have an inappropriate amount of thickening of the LV. Histologically, you guys know what histologically means?
Like tissue type.
Yes, at the tissue level, so the myocytes are hypertrophied and abnormally oriented, so they're not aligned the way that they normally are either. So some of these genetic things are simply because they're not lining up, nicely. They've got this scattered sort of a pattern that's causing that thickening to occur.
So are genetics like the main cause of this?
Yeah, it's a significant part of it. Yes, I'd say that likely they are the main cause, but possibly not the only cause. All right, so my favorite, the obstructive hypertrophic cardiomyopathy. So the ones that we're most concerned about in these patients is the ones that actually obstruct the flow, causing a hemodynamically significant change in what's going on. Mostly this is because it does cause sudden cardiac death. So if we block the blood supply from going out, there's only so long that the heart's going to be pumping before it gives up entirely, effectively causing a heart attack. We've got a family friend whose son died at 19 years old from this, and it was extremely tragic. He was kind of an athlete, but he had asthma and different things like this, and he ended up dying of a heart attack. But this was a sudden cardiac death situation. They found he was driving back from the grocery store and getting some stuff for his mom, and he had pulled over to the side of the road and he slumped over the wheel, dead, and his brother found him like that, and it was just extremely tragic. So again, these are sudden cardiac death scenarios. This is the same type of thing that you would see like athletes or something would be going around and not knowing, because we assume they're healthy because they're athletes, but that thickening can obstruct the flow and it can cause sudden cardiac death. So they are quite dangerous. The good thing is if we can find them and screen for them, we can do procedures that we'll talk about later to fix the problem to some degree so that they can be more normal and they can still resume activity and stuff like that. So seeing is an important thing. So if we have somebody that has it, you remember that I told you guys about the patients that me and my colleague had, and we found out that there's a history of heart disease, of cardiomyopathy that they were looking at, and it was their son that had died a month earlier. That was this type of situation. So when we screen the first degree family members, or the ones like parents or siblings, we're looking to see if they've got that problem. And because it is genetically passed on, there's a strong likelihood that it's affecting the others also. And then they can actually go in and do something about it, or at the very minimum, they can limit their types of activity and what they do to make sure that it doesn't affect them with sudden cardiac death in particular. So that's going to be a specific type, and we'll get more into detail on that. The concentric types, the ones that have kind of an equally distributed thickness throughout the LV, they have little or no obstruction. So they might have super thick, bulky chamber or walls, but the chambers will be small, but it's not actually obstructing the flow. It may be causing other problems, but not life-threatening problems. Apical type, so there's a type where it's just the apex that is thickened, is predominant more in the Asian populations. And this is, again, these are going to be asymmetrical presentations. Both the the Asian type, and obstructive cardiomyopathy, and mid as well. Nancy, go ahead.
When we're talking obstruction, are we specific to LVOT or would it also be RVOT?
It's really LVOT.
Okay,
Yeah,
thanks.
the RV is big enough and dynamic enough, it doesn't really have this problem. We definitely are concerned about the LVOT though. So these can be affected in any area. It could be a mid portion, which also includes the papillary muscles. It could be apical. It could be a septal wall thicker than the posterior wall. It could be posterior wall thicker than the septal wall. There's different presentations. And then, of course, concentric that's equally distributed. The obstructive type is usually a thickening of the septum, a significant thickening of the septum, but particularly at the end of it where it's close to the outflow. Excuse me, those are the dangerous ones because they actually do obstruct the flow. And so we'll get to that in a second. So initially, by M mode, the septal to posterior wall thickness had a ratio of 1.3 to 3. I'm sorry, my dyslexia just kicked in or something. 1.3 to 1. So basically like a 13 centimeters to 10 centimeters type of comparison. We've got ash. So remember that, and again, as we get into the obstructive type, there's two things that you have to consider obstructive, and that's ash and SAM. We'll talk about SAM. We've talked about SAM in the past. That was that systolic anterior motion, whereas ash is asymmetric septal hypertrophy, meaning that the septum is significantly thicker than the rest. The underlying cause could be caused by something else. It doesn't have to necessarily be hypertrophic cardiomyopathy fundamentally. 2D is a primary evaluation tool. So as we're doing our echo and we go into the room, most of our data to prove what's going on here is the 2D information and the /M mode. Nancy, go ahead.
Did I just hear you say it's not alone? I thought it was exclusive. What are we just? What do you mean?
Not necessarily exclusive. There could be other developmental processes that, like infiltrative disease states, that cause that to occur.
So it is independent of other pathology, or it is not?
My understanding it is not totally, but mostly it is hypertrophic genetic type, but it doesn't have to be, but not exclusively. Okay, so 2D and M mode going to be our main tools to evaluate. There's a common gradation of hypertrophy with maximal involvement in the posterior wall and intermediate involvement in the lateral wall and inferior septum. So it's more common in isolated type of septal hypertrophy. So it's kind of distributed throughout. So the septal hypertrophy is not the most common. It's the most hair-raising and exciting ones for us, but not the most common. Concentric forms may not be obstructive. So they are going to encroach on the chamber size for sure. They're not going to obstruct the flow going out the LVOT. There's a couple different ideas on how that works. One is that it actually has kind of I think it's called the Venturi effect, where it actually sucks up the leaflet because of the vacuum going over top of it. And or the fact that it's pulling, the muscles pulling on the chordae tendineae, which pull the leaflet in that direction as well. So there's a couple different ideas on how that actually works. Symptoms develop due to pathological stiffness of the LV and elevated diastolic pressures, as well as pathologically small volumes. So we're getting less blood flow through the heart for stroke volume and cardiac output, just because we can't get enough blood into the chamber. And typically, I will say that you will typically have a pretty decent systolic function. It's the diastolic function that is significantly affected. So the LVOT obstructive cardiomyopathy is the one that's the sudden cardiac death one. So this one we're going to talk a little bit more specifically about now. So this is also called a dynamic outflow tract obstruction, meaning that it changes as the heart beats. Okay, and when we get into talking about SAM, SAM doesn't happen immediately. It's a dynamic process where things start to go out normally and then it changes partway through, dynamically changing. So we're going to detect the SAM. That's an important part of that diagnosis of that anterior mitral valve leaflet. And aortic notching may appear or abrupt partial closure in systole. SAM is caused by, again, a combination of those abnormal capillary muscles and the chordae tendineae being kind of pulled. SAM can be identified in M mode or 2D. So you can see it as you're watching the clips, but it's more obvious, I think, in M mode. So again, there's a lot of labs that actually don't do M mode that much anymore, if at all. But M mode in circumstances like this can actually be quite useful. So even if your protocol doesn't have it and you want to prove it, I would highly recommend using M mode to show that to the doctor. And again, what we're looking for is that abnormal motion during the time that the valve is supposed to be closed. So on this picture here, we've got our E and A waves, just like down here, we got our E and A waves. This is where valve is supposed to be closed. Let me make this a highlighter, laser pointer. This is where it's supposed to be closed in this section, but you're seeing it initially closed and then it's drawn up towards the septum during ventricular systole. Same thing here, we have our E and A wave. This is supposed to be closed all the way through here, and as you can see, that anterior leaflet gets sucked up towards the septum there in systole also. If we were watching a clip, you would actually see this start pushing up in that direction throughout the beat. That might be your first clue that it's going on, but showing that by M mode is probably a better way to show it. And
Would
then
that M mode,
sorry, go ahead.
would that M mode be through the tips of the
Yes.
mitral valve? Okay.
Yes. Just like we usually take our EPSS measurement perspective, it is through the tips of the mitral valve leaflets. You do want to see still the posterior leaflet as well, but we're in particular paying attention to that. So if you see a great big thick septum like this, right by the LVOT, you should at least be looking at the tips of the mitral valve leaflets and see what they do. And if it looks like they're flipping up, definitely be sticking an M mode through that to see what this looks like. Yeah, Nancy?
This is how I remember Sam is from Looney Tunes. I think of Yosemite Sam like got really big because his mustache is really big, and he says to the anterior mitral valve leaflet, "Get over here," and it pulls it when he's trying to dive down the hole like Bugs Bunny.
That's awesome. Yosemite Sam, I love it.
You know, sometimes Nancy's explanations make more sense when you put it like that.
You know, Nancy's a visual learner, I can tell, and probably somewhat kinesthetic as well. And I think many of us have some of those traits as well. I definitely,
I definitely put things in my body to learn it.
It's good. Those are the ways you remember stuff. Some people can do it just by reading and memorizing or listening to it once and learning it. I had a student one year that never picked up a pen. He just listened to lectures and he would ace every test just because he listened.
Those are your doctors.
Yeah. You never know. He might be one day, but he went up to work in Kalispell. Super smart. Yeah, but we all learn differently. So whatever methods you can find to do that. That's why I like with the building of the portfolios that we think about, you know, doing it in your own method that works best for you. I think Nancy's portfolio, she's probably got a house full of objects and stuff that you've put together, right? Like the MRI. That's awesome.
I have a little dresser instead of a bookshelf.
Yeah, there you go. You might have to take a picture of it for me instead of bringing it into the office, right? It's all good. So as you can imagine with this anterior leaflet, as it gets sucked up, the posterior leaflet's only so long, and it's going to open that space as well. So if you had like color Doppler on here, you'd probably also see some flow inside here, similar to what you would see with a prolapse valve. You'd see regurgitation happening. So in this color image of the 2D with color overlay, during that dynamic process, this becomes leaky as well. That mitral valve becomes more leaky, and that just makes sense. But our bigger concern is actually right here, where it's obstructing the flow. So before we talk too much more about this, so let's think about this. So as we're doing the dynamics, we'll get into the spectral Doppler of this. What does a normal spectral Doppler of the LVOT and aorta look like? Just describe the shape for me.
Parabolic.
Okay. Yeah,
In
it's
end mode,
more,
it should be box-like.
so it's more of a pointy parabolic, right? So it's not quite as rounded as like a tricuspid or a mitral regurgitation may be, but it is parabolic and it is more pointy. In this one, we're going to talk about a dagger shape, and you're going to actually notice that it's going to start that way, and then all of a sudden it spikes significantly. We get a big spike in velocity as it goes through there. That's our dagger shape that we'll show here in just a minute. That's going to be an important part of this. So why did I mention that? I don't even know. It's an exciting pathology for me. I like this stuff. And I've actually scanned patients with this too. It's pretty interesting. So SAM obstruction is more likely present when mitral valve leaflet makes direct contact with the IVS. So if it's actually coming up on that M mode and you can show it touching the IVS during ventricular systole, that's a more significant outcome. The early part of the LVOT ejection, like I say, is usually normal. So it starts out in that normal, around 80 to 100 centimeter per second, starting into that parabolic shape, and then it will spike with that dynamic change. So the obstruction occurs mid to late systole, and it's concurrent with late phase of LV contraction. And the flow transiently diminishes. The velocity, though, will spike. The diminished flow volume can cause the aortic valve to close early and often secondary opening at final ejection. So as that's going through that dynamic change, as you can see down here on this aortic presentation, it opens, it kind of shuts a little bit, and then has a reopening again near the end. So it's going to have a very different shape. Again, the low cardiac output thing. So normally when we talked in dilated cardiomyopathy, the end of it had that curled in view because it was shutting early because of low cardiac output. When we have flow obstruction, it's not keeping that aortic valve open. So we're getting this jittery type of an appearance, maybe with a little bit at the very end of the cycle. So the actual flow going out is going to be cut off to some degree, even though our velocity is going to spike very significantly. Okay.
Hey, Scott.
Yes.
Why does it look like the right coronary cusp and the non-coronary cusp look all like fluttery?
That's part of what's going on with the dynamics, and it's fluttery because these are highly, highly turbulent.
Oh, so just the turbulent flows. Okay.
This is turbulent flow immediately post stenosis. So the aortic valve is not the stenotic area. This is a subaortic stenosis. So, now there's a difference. There's a subaortic stenosis, which is like a band of tissue or something that comes across the LVOT area that always obstructs the flow, versus this dynamic obstruction caused by the muscle and that anterior leaflet coming together and blocking the flow. So there's a bit of a difference there, but that, yes, that fluttery nature is because of that extreme turbulence that you're going to see. And these velocities are going to go quite high. So when I scanned this one guy, we did a stress test on him. I don't know if we knew that he had one before we did the test. I think in the resting echo, I think we found and suspected this to be occurring. And the cardiologist wanted us to do this study anyway, which is kind of dangerous. There's certainly a higher risk to it, but we actually did the stress test and then we Dopplered through the LVOT after the stress test. So he's done the treadmill, he's back on the bed, the 60 to 90 seconds after before we start Dopplering. And we were getting spikes, velocities, and with the 4V squared Bernoulli equation, we were getting 300 millimeters of mercury of pressure through there. Okay. So remember, we said yesterday, I believe it was, that if you exceed on an LVAD 300 millimeters of mercury pressure, that will blow out the aortic valve. So that's a very high pressure. And that's what we were getting after he was done the test. So likely during the test, it was even higher than that and or completely obstructing. And that does put the patient in a very high risk of having a sudden heart attack and sudden cardiac death.
But he lived?
He was fine, yeah. So he was symptomatic, and we pulled him off as soon as he was symptomatic.
That
weren't
seems
taking-
so dangerous.
Well, we worked in the cardiology office. So when you work with the cardiologist directly on these stress tests, they have a higher tolerance of acceptability because they are the expert, right? Now, I wouldn't recommend an internist do that because we did lots of stress tests with internists, but they did not have the cardiac expertise to deal with those types of risks. Same thing with people with cabbages and stuff like that. A cardiologist will push harder than an internist would, appropriately.
I'm not even sure if I want to be involved in something like that.
Yeah, like I say, stress tests are sometimes more stressful on us as the techs, but it's interesting. So again, we're looking for that obstruction to occur mid to late systole, and I will be showing some Doppler examples of that as we continue on. And then there might be some aortic valve notching as well, sort of that mid part of the cycle. Again, as the obstruction becomes really bad, it actually does obstruct. Those valve leaflets are going to come closed because we're not pushing enough volume and pressure through to keep those leaflets open. It doesn't mean that there's anything wrong with the leaflets themselves. In this particular case, it looks like the valve leaflets are somewhat thick inherently. They're thicker than we would normally see them, but that's the least of our concerns at this moment. 3D can show promise for refining definition and distribution of the cardiomyopathy. So if we can take a 3D image rather than just a 2D slice, we get a much better representation of what's going on globally through the heart muscle. Cardiac MRI, thanks to our MRI folks yesterday, is very useful. 3D has not proven to be similar in capability. So going back to that gold standard idea, that would be much more reliable information than what we can provide. MRI is cool. In some ways, I wish we could just jump to MRI from echo, because that would be a lot of fun. All right, so Doppler. So now we stick the color Doppler on, as I alluded to earlier. Yes, we're going to get that flow confluence through there. When we become stenotic in any way, we start to get a convergence of flow, which gives us that forming aliasing through that area. And it's also going to possibly cause valve leakage on the mitral valve because it's pulling the anterior leaflet away from the posterior leaflet. Pulsed wave we use to track the flow and to determine where the peak will occur. Okay, we use color as the high scale to narrow it down. So in other words, we're going to put our color scale up higher so that it narrows down that aliasing amount so we can pinpoint where exactly it's occurring. Because if I have just a whole bunch of aliasing, it doesn't really tell us anything. So increase your color scale to narrow down where that highest flow really is. Yeah, Nancy?
Okay. Oh, sorry. Can you explain it to me like I'm 5? How we use the pulse wave and then when we change it to CW? Because right now we're pulsing the LVO, we're PWing the LVOT. So how and when do we know it's going to be a dagger, and I'm just barely starting to understand how to work the color on the machine. So I pretend I don't know anything about this.
Fair enough.
Would it be when we did like suspect the highest velocities, like when we need to get the highest velocities, like get the dagger shape?
Yes, so when we want the highest velocity, then we definitely want CW. Okay, the initial part is just getting the waveform and seeing it. So let me give you a question to help answer the question. If why would I use a pulsed wave rather than a CW for something like this? You think? What benefit does PW give us over CW?
So,
Location specific.
yeah.
That is exactly right. So we go location specific because if I throw a CW through the LVOT and out the aorta, what is normally the highest velocity?
The aorta.
Aortic valve, yeah. So we don't want to see that something else is causing that spike. We need to see that it's not the aortic valve itself, but we need to see that it is, in fact, the before the aortic valve or subaortic. That's important. So if we can show the color Doppler narrowing in that area, we show the ash, we show the SAM, and we show the pulse wave sample in that area where you see that high velocity aliasing with your color scale up, that will help to narrow down exactly where it is. So Nancy, back to your question on the color Doppler, when do I use the, there's only a couple times where you really use changing velocities or the PRF of our color scale. And why, so let's just talk generally speaking about color Doppler. Why would you want to increase or decrease your color scale normally? When have you used it?
On ASDs and subcostals, then I put it down.
Okay, okay.
When you suspect like aliasing or slower flows like dilated cardiomyopathy.
Yes, good. So those are great examples. So when I see a color flow that's so low that maybe where my regular color flow is, it's getting that dull appearance. It may not be getting out to the edges of the chamber or vessel that I'm interested in. That's when I would decrease it, okay, so that I can detect it and see it. They do that often, as Nancy mentioned, with ASDs and PFOs and stuff in the subcostal view. We've got that nice 0-degree angle. And often we do that because it actually helps to compensate a little bit for the artifacts that we're getting. But I will say that most of those jets are actually going to be fast enough that we don't really need to drop it down, but it will accentuate it. Okay. And we do have to be careful of it not to change it on things like a regular aortic regurgitation or something like that, because if we drop our color scale, it's going to overemphasize what it looks like and make us call it bigger than it really is. So that's important to leave it, normally speaking, in your normal range that's defaulted on the system on the preset. But it's perfectly acceptable to drop it down when I've got those low flow states and I want to show the flow all the way up to the borders and stuff like that. So that's totally appropriate. Having said that, of course, we always want to bring it back to the normal preset as we continue our exam while we're looking at other valvular structures and so forth. Now, the opposite is true with that, and I would say this is the same with like a carotid stenosis or looking at an abdominal aorta, or going from the difference between like a proximal renal artery to a parenchymal type of an artery like an arcuate. They require different scales. There's different flow velocities in those ranges. Remember, color is just a mean velocity, and so if I start to get that aliasing and things are normal, I usually will adjust my color scale up so that it's not. And I know that there's not a stenosis. I know that there's not a plaque buildup or something like that that's causing it. I might increase that so that I get a more uniform color. Because in my opinion, if something aliases, that indicates that there's something not right. It's abnormal. So if I've got too low a scale on a vessel that doesn't require that and it's totally open and normal, that's an inappropriate color scale setting. With these high velocity things where we start to get a ton of turbulence, if I increase my color scale, that narrows it down to show me just exactly where that stenosis is. So it kind of brings it tighter and helps me locate it more specifically. And that's where increasing my color PRF or scale in this case will be very helpful to narrow down exactly in the LVOT area where that highest velocity is. Because when we pulse wave it and look for this dynamic flow pattern change, we're going to be walking our sample volume all the way through that area, back and forth, up and down. We're going to be looking to see where the obstruction is actually occurring. And we can narrow it down by increasing our color scale to tighten that aliasing representation that we see. Does that help? Yeah, I mean, you kind of got to see it a little bit to get an appreciation for it. It's similar to the concept of us changing our baseline for PISA. The reason we do that is not because it needs it in the formula, it's because it helps to visually make our mushroom, that dome, bigger and more accentuated so that visually we can see it and more accurately measure it. So that's why we do it. Similar concept. Except we're going opposite in this case, where we're actually increasing the scale to narrow down the tightness of that space and that actual stenosis.
So what does it look like? Does it look like sparkly speckles aliasing? Is that what I'm seeing?
So like this here, this is the aliasing here. If I were to increase the color scale, it would narrow down, like all this aliasing stuff that's going on here would start to get smaller into a more compact area. And the most residual, most center part of that's where the highest stenosis is.
And then that's where I want to put my CW guy.
Pulse wave first in this case. We might CW it after as well, but pulse wave because we need to locate it specifically.
Right. But then will it alias and be too fast?
Yeah, it will on your pulse wave, but once we've shown that dagger shape, it's more the shape that we're looking at rather than the velocity. And then if you want to measure the peak velocity or see the whole envelope, then we will put a CW through it also.
Okay.
Which we will typically do. But the shape of that dagger is a diagnostic marker for the obstructive cardiomyopathy. And then just taking the concept of pulse wave versus CW later, if I take my pulse wave and put it in that LVOT area where it's aliasing, I get that spike in velocity. If I then take my pulse wave and put it down into the tips of the aortic valve leaflet, you would likely see the flow velocities decrease. You might still see some dagger shape though, because it's still going through that area. It's just not as prominent as that highest spot.
This is just like stenosis. Ugh.
Yes, it is a stenosis. Except this stenosis actually gets to the point of dynamically actually cutting it off. So what we're concerned about on aortic stenosis is when it gets into that severe to critical stage. That's a slow, gradual process. This one is doing it. It's going from open to completely blocked off within microseconds.
So it's dynamic stenosis.
Yes, exactly.
Okay.
So
All
would
right,
velocity be similar to aortic stenosis? Like anything greater than 4 would be severe there at that specific sub-aortic?
Yeah, if it's spiking over 2, it will go easily up to 4, maybe even 5. I mean, it gets very high velocity. It will be pretty obvious what's going on, or it should be pretty obvious what's going on, hopefully. But remember, the narrower we get, the harder it is to keep that sample line in that space, because the tinier it is, it's easier to fall out of it too. Okay, so getting a good lined up 0-degree angle, getting a nice perspective where it keeps it throughout the whole cardiac cycle, that's going to be important. And then if we are determining again that highest velocity, we definitely need CW to obtain that. The location is not in question with SAM. So that statement out of the book just indicated that if we are running that CW through there, we're looking for that dagger shape. I'd still say the location is somewhat important, but if you're seeing that on spectral Doppler, that gives you the answer. All right, so I think our next picture, we start to get into pictures of this, but we'll talk about it just a little bit more. So we got what's called the dagger shape. I actually don't think it looks like a dagger. I think our regular aortic valve flow and stenosis looks more like a dagger to me, but I'd call it more like a sharp tooth, and you'll see what I mean in just a minute. So visually, you can choose what you want, but it is considered officially dagger shape. So look for that term. If you're taking a registry exam and you hear dagger shape, then you should automatically be thinking of this. This is like the one pathology that gives that presentation. Often evidence of pre-systolic flow in the LVOT occurs during atrial contraction. Many signs and symptoms of adverse clinical sequela of HCM are independently outflow tract obstruction and are related to diastolic function, reduced stroke volume, or secondary pulmonary hypertension. Just a lot of stuff saying what we've already talked about. If echo still shows evidence, don't exclude hypertrophic cardiomyopathy. Attempt to provoke a gradient using something like Valsalva maneuver, amyl nitrate inhalation, isopropyl or isoprel infusion, or rapid standing from squatting positions are ways that you can test it. In addition to that, as I already suggested, some doctors, not very many doctors, will do a stress test on that also. So those Valsalvas and stuff like that are they're going to increase those pressures and cause enough strain to maybe make it more evident. So you can use those techniques. Valsalva is going to be obviously the easiest one for us to do, and doesn't require any kind of a IV injection or anything like that, or the standing from squatting.
Yeah, good luck keeping your window.
Exactly. Yes.
And since it's a narrow opening, your pulse wave.
Yeah, no kidding. Trying to keep it all together. And you're going to realize how difficult it is. Again, just the difference in breathing when a patient's after their exercise. I mean, you know how hard it is to get the right breath right now. Imagine a patient that's panicking and breathing and stuff like that very quickly and heavily at the same time. It changes where your windows are. So the exercise testing should be performed in a physician monitored setting. So I was talking to Tyler yesterday, and he said that he often did the stress test by himself. Didn't have a nurse or an MA or a doctor in the room with him, even though the doctor was next door, which I personally would not want to work in that situation. But in these situations where it is a high risk of something happening, I would definitely want to be having a physician in the room with me because they get to take the responsibility. I don't have malpractice insurance, so. Okay, so here's an example of the dagger shape. Okay, so let's look at the normal aortic stenosis profile. So this is 3.6 velocity. We've got a sort of parabolic pointed waveform here. Notice how it peaks about mid, okay, about early to mid portion of that jet. This one, if I was to cover up, I don't have a way to cover it up on the screen here. So as we're progressing through the systole, through the aortic valve, you can see that this is a normal looking start to an aortic valve profile, right? This would be like a slightly faster than normal up to this point. We would expect it to peak around here and then come back down like that parabolically, right? So what's happening with this dynamic is it's coming along, it's open normally. Now that mitral valve leaflet's coming up to block off the flow. And then all of a sudden I get a big spike in velocity that happens late systole. That is our dagger shape. So this clue that halfway through the cycle, it just all of a sudden spikes, like significantly spikes. You can see that this is probably over 6 meters per second. Where they're measuring it here is 5.6. There's just artifact beyond this, but that more than doubled basically. Okay, on the late systole. So that is your classic Hokum appearance. If you see that, you definitely want to be looking closely at what's going on.
Hey Scott, that diastole part of that waveform there, is that the AI? Because it looks funky.
It does look funky. Is it AI? It doesn't give us an AI jet, but we are gained differently. So there might be some more of that we see. So there could be some AI there. Likely we just got some stuff moving around in that spot. So if you just blocked off that spot, I got a little bit of blood that's in between the LVOT and my aortic valve too, and the aortic valve is shut. So when that ventricle starts to relax, it's pulling that little pocket of blood back. So likely that's probably what it is, with
Okay.
just the general ventricle type of swirling. It could be some AI, but not necessarily based on this image. Okay, so MR is common with hypertrophic cardiomyopathies. And again, so we're kind of leaving the whole concept of HOCM, the hypertrophic obstructive cardiomyopathy, and just going more broadly again. So with this, MR is common. In the HOCM it was because it's actually pulling the leaflet open, right? And in just regular hypertrophic cardiomyopathy, again, the whole idea of those chordae tendineae being pulled around the edges of the muscle and being stretched out that way is causing the malcoaptation of those leaflets, and it's allowing that to happen. It's allowing leakage to happen. Most often cause by malcoaptation is due to SAM, so that's systolic anterior motion. So that would be a HOCM situation. Is most common, but it can affect it in other types of hypertrophic obstructive hypertrophic cardiomyopathy. Typically, it's central, but it can be eccentric. May predominate in mid to late systole during maximal SAM. So when it is SAM, it's going to be late systole. Can be mistaken as the LVOT flow. I don't know how that's the case, other than I'm just trying to think of when I would see that. That would only really be if your Doppler happened to fall into the tips of the mitral valve leaflets when you're trying to get the LVOT flow. So it is kind of the same area. If SAM is coming up and it's there, that is the tip of the leaflet. My continuous wave should be running on this side, but it might slip into this side. So it's going to capture some of that. But obviously, it's not going to give that dagger shape appearance if it falls into the mitral valve. Consider MR when encountered at late peak and is greater than 6 meters per second. So again, that is the SAM, the hypertrophic obstructive cardiomyopathy. And just remember when you're looking at differences of mitral regurg versus aorta, the IVRT difference of when that flow is occurring is going to be important. So even with our dagger shape, it's still going to have an IVRT and an IVCP, whereas a regurgitation just starts immediately upon valve closure and stops upon valve opening. Okay, variants. So we alluded to the fact that there's other types of areas of the heart that could be thickened. So let's talk for a second about the apical ones. So again, that is more predominant in Asian population. It's often associated with deep symmetric T-wave inversion on the precordial leads on your EKG. Okay. This classic shape is called the spade shape, and we'll show that here in just a minute. So as you can imagine, our ventricle is normally bullet shaped, okay, somewhat parabolic, pointy at the tip there. And if we've got apical thickening, it will start to come up and then it's going to curve in significantly, giving us a little skinny peak on it that we'll show here on some images coming up. In fact, if we look at this MRI at the top here, this might be a CT actually, you can see that this apical wall up here is thickened and it kind of comes in there a little bit. It doesn't have that nicely peaked with nice rounding coming into it. This one's more predominant where you can see the chamber coming in and then it significantly comes in and narrows with a little bit of a neck sticking up into the apex. Okay, so that is that spade shape that we're talking about. We're going to look at that on echo as well. And you may actually need echo enhancing agents or like a Definity or something like that to see that really well because of all the artifact that we get up in the apex. Usually this, if they've got this apical thickening, it's going to be asymptomatic and it might have EKG abnormalities that we just discussed, those T-wave inversions on the precordial leads. What other thickening, what were signs of thickening on EKG that you remember?
Was it the T wave?
Not the T wave. It was the height of the QRSs. Yeah, so remember, hypertrophy on EKG was indicated by the strength or the height of those EKGs. And so that can be wall specific if they're in regional areas. So that's another clue that could be found on EKG. These can be overlooked by echo, particularly with low frequency transducers, because again, that apex is a difficult place to inherently see. And we tend to get a lot of artifact there anyway, just from rib shadowing and different things like that. So you might need to use, again, your echo enhancing agents or contrast. We can identify a spectral gradient near the apex. So normally we're not taking Dopplers near the apex. That's like hardly ever anything we ever do. But if you see something like this, you can stick your color Doppler on. And this is one of the reasons when I take my color Dopplers, I like to have it go through the valve that I'm interested in. But I actually make the height of it go right up to the apex because then I can see the flow all the way to the apex. And if you're seeing an aliasing velocity in the center of that chamber up at the apex or even the mid portion, you can actually pick up a gradient even though you may not have thought that the walls were super thick. So that color flow can be your first clue from that perspective. And then if you stuck a pulse wave in it or even a CW, you can see how fast it actually moves through that area. I actually had one patient and I didn't really know what to do with it. And one of the owners of the company, who was also a very experienced echo tech, I asked him one day because I found this mid cavitary gradient, which we'll also talk about. It was right in the middle of it, right by the papillary muscle level. And with color Doppler, I could see this aliasing velocity as it was squeezing together. And like, we determined that it was a cardiomyopathy and it was mid, but I'm like, does this do anything to the patient? Like, do they have symptoms and that kind of stuff? And I think in some cases they can develop problems long term. But it was kind of a weird thing for me because I'm like, well, we don't normally Doppler here, but let's take a CW through it. And it definitely had a big spike in velocity. And to some degree, it will affect the hemodynamics, but not like it would on an obstructive case. So we determined that it's something to note, but doesn't really change the outcome, at least from our perspective. They can still have ischemic disease, and they can still and they can develop apical aneurysms as well in these cases. So this is again still specifically the apical type of hypertrophy. All right, and then the one that I just mentioned with the papillary muscle level, so you can get it in the mid cavitary. Really, the clue is to see and to note the size of the walls going through that area. So we'll take our 2D measurements through there. But you might also use color Doppler and see those aliasing velocities through the middle. And if you get a picture like this one down here, the green is that variance map that indicates turbulence, but you can see there's a lot of aliasing through the middle of here. If you, again, want to accentuate that, that would be a time that's appropriate to increase your color PRF to show and narrow down where exactly that's occurring at. Just, again, be sure to change it back to normal. Yeah, Kelsey?
So what's the more common type of subaortic obstruction then in this situation? Is it concentric, or is it asymmetric, or is it SAM, or apical, or mid-cavitary?
I mean, they're not super common. It's more common to have just generalized thickness. It may be asymmetric, it may be global, but typically those are not affecting. Again, the ones we get excited about are the hokum, because it's obstructive and very dangerous. But I've seen many, many more just thick walls generally that aren't really obstructing flow and aren't really changing the hemodynamics much. That's more common than a hokum is, but a hokum you definitely want to catch. Does that answer your question?
Yeah, I was just wondering because I think earlier in the PowerPoint you mentioned something about septal and the apical level not being the most common or something.
Yeah, I'm not sure what exactly the most common. I think from my personal experience, just seeing, I've seen a lot of septal thickening, but I've also seen posterior wall thickening. Not a lot of apical thickening, but I was in Colorado Springs too, so that might be due to partly the population that we had there. And somewhat global. I don't know, from personal experience, I don't know how much of one I've seen over the other. I personally would say I've seen more probably septal ones, but again, that could just be where I was. Nancy, you had a comment?
Yeah, so is what I'm hearing you say that basically the whether it's apical or mid cavitary obstruction, if it's not causing change in the hemodynamics, it's just noteworthy rather than like, or like, yeah, you have it, but no big, like, not no big deal, but meh.
Right. And
it's not going to change your life, or
yeah, it's not going to significantly change the hemodynamics for that patient. Could it end up in some problems down the road? Yes, it could. Especially for me, I think a mid-cavitary one potentially, and this is what my the owner of the company and I decided, was that, and this is just us discussing it philosophically, was that potentially if I've got that mid-cavitary gradient and it's squeezing, it's actually blocking the blood down the middle part, leaving a pocket of fluid up at the apex. That could long term maybe cause, it's sort of like that squeezing a tube of toothpaste in the middle. It could cause aneurysms and stuff to occur potentially. That was just us philosophizing about it. But they may have found more stuff recently, so it really will depend on the comfort level of your doctor and what they want to do. But if you ever have cases like that, I think it would be interesting to ask your cardiologist what they think about it. My guess is that if it's typically a cardiologist, if things are asymptomatic, they don't do a lot about it. And typically these patients will be asymptomatic. Okay. So with that spectral Doppler, you can get a gradient in the middle, meaning you got that spike in velocity in the middle. Again, what does it mean? If it's not symptomatic, they're probably not going to do anything different. But I think it is important if they do find these genetic causes of things. We're talking about the heart here specifically, and likely of those 1,500 genetic possible things, my guess is typically, and scanning OB, if you have 2 or more soft markers for something, there's likely genetic causes. And so the take-home story is that when one genetic cause is causing my heart to have abnormality, what's the likelihood of something else in the body being affected? So from a global health of a patient perspective, knowing what that is might be an important factor. So if that Asian population had that apical thickening, maybe, and I don't know this, but maybe there's some genetic correlation to some other organ system that is being affected also. So that could be noteworthy at a very minimum to know that. And if they thought there's something important, they might actually do a genetic test to see what they actually have and what they can do differently. Maybe not for the heart, but for the body as a whole. Okay, so we could have an effect of long-standing hypertension with a small LV. So there's a particular situation that Feigenbaum talked about that, and I think we talked about this with our ICU type of patients, and that where we have a low volume because the patient's bleeding out somewhere, and they had a history of long-standing hypertension that caused thick walls to occur. But because of that small volume of LV, it's actually causing a dynamic obstruction, just like a HOCM, but it's not actually HOCM. Okay, and that was just one case that he talked about in the book there that we just wanted to mention. We did talk about that before as well. And the way they would fix that is that they would hydrate that patient, give them some IVs and stuff, build the fluid volume back up, and that dynamic obstruction would disappear. Contrast can be needed as well, particularly not necessarily on the mid-cavitary obstruction. You can. You could also use it on the apical one to help see that what do they call it? Oh, it just left my brain. Oh, the spade shape. To see that spade shape, it might be most obvious with contrast. Okay, you might not see it very clearly with 2D alone. Maybe with color, most likely with contrast. Okay, so if, again, we're having these patients that have these, particularly the obstructive cardiomyopathy, again, it's being a genetic cause, we want to screen family members. So they will often take in those first-degree relatives, being your brothers and sisters primarily, but also parents. Echo is a standard method due to the cost and the ease of performance. So our stronghold in the imaging world is because we cost less. But we can be very good too. But compared to MRI and CT, even nuclear medicine, we have a significantly less costly exam. Screening should be done annually until they're 18 years old, and then every 5 years after that for family members that are found to have a genetic connection to somebody else. But we don't want to screen them once and be like, yep, you're good, you never have to do this again, because those things can develop down the road, particularly when they're in those growing years. It's also been noted then recently that there is an abnormal twist or torsion in patients with hypertrophic cardiomyopathy. No proven significance to that. And if our cells are misaligned, as is found in these hypertrophic cardiomyopathies, then that makes a lot of sense that it wouldn't necessarily squeeze the same way a heart that is normally oriented would. All right, any conditions causing greater septal or posterior wall thickness could be confused. hypertension, concurrent CAD with inferior MI, for example. Um, so again, we're looking at the muscle thickness. So what's important when you see muscle thickness differences? So if I see a posterior wall that's thinner than a septal wall, what things are, so measuring it is obviously important. What else is important when you're evaluating those walls?
Would it be determining like ischemic things?
Yes, so look at the thickening. So Nancy's sign language there, I'm guessing that means to look at the thickening. If it's not thickening or it's hypokinetic, then yes. If it's equally thick and they still seem to squeeze reasonably, then you're probably dealing more with a hypertrophic cardiomyopathy. But if it's thinning and stuff like that, a poor ejection fraction on that regional segment, those things are important to note because then it would be CAD instead. And of course, any akinesis and scarring in particular as well. Scarring again is going to be typically less than 6 millimeters in thickness, and it's going to be brighter walls than the other segments are. Even though it's moving, doesn't mean it's thickening. Looking at things like discrete submembrane or subvalvular membrane. So the picture down there. So I talked about a subaortic stenosis, which is kind of what's happening with a HOCM. This band of tissue down on this picture is actually causing an outflow obstruction right there as well. So this is a little band of tissue that's coming across there. So you can get these types of bands below or subaortic, but you can also get supraaortic stenoses as well, like some types of coarctations that are close to the aortic valve. So the valve itself is not the only area that we look at stenosis. So that could be happening in that location. It's fairly common, especially with newer ultrasound systems, to see the details so well. I've seen several patients since I've worked here, even students, that have a band of tissue that goes all the way up to the LVOT. Sometimes they call them false tendons if it's just a tendon, or you could see a band of muscular tissue like an extended tuberculation. That type of stuff does happen. As long as it's not obstructing the flow, it should be fine. Okay.
That's not Lamble's excrescence?
No, because Lamble's excrescences come right off the valve tips themselves.
I think Tammy was talking about this on
Mhm.
her AV stuff. And then she said that if you go in and cut it off, it will just grow back.
Yeah. It's like a polyp. I'm told, like, I had to have a nasal polyp removed, and they said that they likely will grow back.
So do we know that if it's causing obstruction by the velocity of the flow?
Yes, yes. So when you stick color Doppler on there, you're going to see a spike in velocity similar to an aortic valve stenosis. It won't be the dynamic one like the dagger shape because it's not changing as it goes. It's just there. And it will just have spiked velocities. You'll notice that your LVOT velocities are higher than they probably should be inherently, and then it doesn't change a whole lot through the aortic valve itself through that. Hopefully, we're seeing these bands and stuff in 2D before we put on the color Doppler and spectral Doppler to see that. So all of your information should be fitting together at that point. But there are chances we can miss stuff, and if you have a lot of shadowing, it's easy to miss a small band of tissue if the shadow went right through that spot. Okay, so look for those little subvalvular type of membranes. Look for the presence of AI, which is rare in hypertrophic cardiomyopathy, but is common with membrane issues like this. Okay, so if they've got AI, you should be considering those other types of stenosis. Prominent muscle bundles or trabeculations will be in the RV. So these are things mimicking hypertrophic cardiomyopathy. So just getting thicker muscle bundles. And this is probably the most common one that we do, especially early on. When many of you are taking your measurements, it's not uncommon for us to be at a low window. And particularly if we're going through M mode, you have to be sure that your cursor is not going through like near the apex and then towards the base on the posterior wall, because we'll make our septal wall look thick. Okay, and if we've got those prominent trabeculations in the right heart, we might include those on our septal wall measurement inappropriately. So make sure that you're seeing the compacted part of the septal wall when you're doing the measurement. So any right ventricular hypertrophy is also going to affect the thickness of the septum as well. So if somebody's got like pulmonary issues, they might have a thicker right heart, which will make the septum thicker than the posterior wall as well. And that, for me, may have contributed to why I personally saw more septal thickening than posterior wall or other areas, because living in Colorado Springs, we were very high elevation, and patients often had higher pressures, pulmonary pressures, because of that high elevation. Pulmonary elevation sickness is a big deal there, particularly for visitors. Important to note any pulmonary hypertension causes of that as well. So of course we're taking our CW of our tricuspid regurgitation and finding what the pulmonary pressures are roughly. Spontaneously closed perimembranous VSDs. So again, those are just things mimicking. I'm not sure how that, because I haven't seen one of those. I'm not sure how that spontaneous closure causes a mimicking of a hypertrophic cardiomyopathy, but presumably it does. I just haven't seen
Maybe
it.
it was hyper growth of the cells as it closes, like, oh, we got to patch the hole, and then they really put a huge dam in it.
Yeah, really big. And the spontaneous closed ones means that we didn't actually go in and do a procedure either. So it's not a implanted device, it's just the way it grew. So presumably that
Maybe an
more scars.
overcompensation.
Yep. Mechanism either by tissue growth with aneurysm formation or the portion of the tricuspid valve seals over the defect. Okay, so that could be just more things of tissue adding to that thickness. Angulation of the septum may be dramatically altered, protruding into the LVOT. That'd be interesting. I haven't seen one of those. All right, acquired hypertrophic cardiomyopathy of the hypertensive elderly. So again, somebody with long-standing high blood pressure has those inherently thickened walls anyway. And remember, our hypertrophic cardiomyopathy was that 13 millimeters or greater, so you might be kind of cutting that borderline and just have to have good measurements to show that. It's easy to overmeasure a wall by a couple of millimeters. They develop thick wall due to hypertension. Remember that the septum on the elderly can get that, what they call that sigmoid septum, or that curved in septum. So that if we're measuring it wrong, particularly on M mode, and we're just doing a straight measurement across it, that's going to also make it look thicker than it really is. That can be mistaken on 2D as well if you're not careful in how you place your calipers. They can still develop some gradients and SAM, but not to the degree that HOCM was.
Sorry to interrupt again.
Yeah, go
You
ahead.
do want to place your caliper though on that sigmoid part, right? Across from the, so if it
You
goes like
can.
swoopy down like that.
Just make sure where it's turning. I'm not measuring this way. I'm measuring the thickness of it this way. So make sure that you're perpendicular to the muscle, whatever direction it's going.
Yeah, figure 1852 shows it.
Let me grab it real quick.
It's page 535.
Yes. Yeah, so just making sure that you're perpendicular and not obliquing the measurement, because obliquing, it's going to make it measure bigger than it is.
Okay, I got you.
And that's probably the most common mistake with that one, is that techs don't really think about the perpendicular nature to the direction of the wall. They just measure it across.
So then you would measure that way, but then would you make not even you wouldn't follow that line. You would go straight down.
Yeah,
to measure.
So for me, I would always measure the widest part.
Mhm.
So where my finger is here, so that's that picture for lighting. So the septum is down over here. I would measure perpendicular across the chamber where the widest part of that chamber is. So I've been in circumstances where I've actually measured across the way that you do, especially if it's M mode and you can't move where it is, I will take a separate measurement of the chamber and a separate measurement of the wall where I think it's thickest or thinnest, even though it's not part of that package deal. And talking to Dr. Feigenbaum, he actually agreed that he likes to have, he doesn't take his measurements straight across like we do standardly. He wants to know where the wall is the thickest, where it's the thinnest, and where the chamber size is the most dilated. And they may be in different locations. So as a doctor, that's what he wants to know. Even though we take our standard line across there and map that path. But as a lab, we want to do things consistently the same. But I would also, I would often add an additional measurement if I thought that it was necessary.
Okay, cool. Thank you.
And then they can do what they want with it. Okay, so in those patients, the elderly patients with that curved septum and the hypertensive wall, there's no family history or other true features of hypertrophic cardiomyopathy. Amyloid infiltration, when it's not uniform, can cause mimicking a asymmetric septal hypertrophy. But otherwise, amyloid will typically be diffusely representation. Athletic heart, again, athletic heart can cause the muscle walls to be thicker than they normally are as well. It could reveal higher systolic and diastolic annular and wall velocities compared to hypertrophic cardiomyopathy. I gotta jump out for just a second here. I'll be right back.
Have you guys looked? Next lecture on this is like a handful of slides. It's like we're covering all of it today, it feels like.
I was
Yeah.
worried that we might not even get through it today.
Oh, my talking doesn't help with that. Casey, sorry.
No, it's a long PowerPoint. I'm looking at it right now. We just got halfway through, just a few slides past.
Are you kidding me? Crumb.
Yeah, this one's like 37 slides. The next one's only 10.
Yeah, we're probably wrapping around then. His class is over technically in 7 minutes. I'm looking through the book with it, that's how I follow along. And like there's nothing left.
Julianne? Julianne?
Probably Jillian's mom.
Yeah, Julian's sleeping.
I know, I heard that and I was like, it's Kathleen.
I should have changed the name.
No, but aren't you in here twice?
I am.
Okay.
Yeah, I usually do that if I this is gonna sound weird, but if I have to go to the bathroom, I'll log in again.
Now that totes makes sense if you're at a desktop. I just take my iPad with.
Right?
Speaking of which, I need to do laundry.
All right, sorry about that. Okay. So ischemia in the distal LAD and dobutamine. So dobutamine we might be doing, might have the distal LAD. What would the distal LAD affect, do you think, on what segments of the heart?
The apex and the anterolateral wall. No, lateral wall.
Yes.
Anterior wall. Gosh darn
Yeah.
it.
So LED is going to run down the middle, mostly affecting that anterior wall. It can go a little bit lateral as well. Distal is usually going to be apex in particular. So like these pictures down, oops, dropped the mouse.
By the way, your camera's still off, just FYI.
Oh, sorry. Not much to look at here anyway. So like this picture suggests down here is we get, you could have an affected wall segment being aneurysmal, might be hypokinetic. So you get that rounded apex, and it may look like it's a proximal thickening from like mid to base, like these images here show. In diastole, you may not notice a big difference. When it squeezes in systole, you would notice it. Okay, so it's kind of squeezing in here, but it's not up here. So again, that's just the difference. And again, these conditions mimicking this, we want to look at the wall thickening and all the different wall segments. Similar phenomenon to apical ballooning syndrome, or that Takotsubo's. We've talked about Takotsubo before, right? That octopus trap. So again, it's that
Yes.
that's the broken heart syndrome, if you remember that. It's a real condition. It's been very diagnosed over probably the last 5 years or so, and it's been shown a lot more. And that's with severe emotional stress that can cause a mimicking of CAD, even though it's not CAD. It's kind of spasming of those arteries. So this might look similar to that, without the intense emotional distress. End stage hypertrophic cardiomyopathy. So we have an inappropriate amount of thickening without hypertension and LV systolic dysfunction. So this is end stage now. The systolic dysfunction starts giving out in addition to our poor diastolic dysfunction. It occurs in patients that has hypertrophic cardiomyopathy, but where the global ventricle is kind of burned out. So again, it's just kind of giving up, and we have a globally hypokinetic heart. SAM may be gone, and patient is having mildly dilated but hypertrophied cardiomyopathy. All right, so the real question in the end is, we determine these wall thicknesses, we determine the regional segment that it's in, or if it's global. The question is, what can we do about it, or what should we do about it? Of course, basics of all of that is we want to treat with medication if we can. That's our first step. Surgery is going to be kind of our last option. But we want to decrease contractility with things like beta blockers or calcium channel blockers. Okay, and it's noted that it might have some limited success with those. Substantial success with myectomy or alcohol ablation. So what do you think a myectomy is?
Removal of myocardium.
Okay, it is. And in particular, we're talking about the obstructive ones. So if it is obstructing flow, they'll actually go in and cut out part of that obstructive muscle. Which has an effect. The downside to that is that when we cut something out, well, obviously we have to do open heart surgery with that, or something to go in and actually cut it out. So we're going in, we're taking out a piece of tissue. There might be some inflammation along with that, but we're going to have an immediate effect with that. So it's immediately going to remove the obstructive nature of that. Or they do alcohol ablation. Have you guys talked about alcohol ablations with Darren's class?
No, but that's where they wouldn't they like burn part of the tissue away?
Yeah, essentially. So what they do is they go in with the cath lab and they go right into the coronary artery, into the branches that supply that little septal segment that's causing the problem. And they're injecting alcohol into those coronary arteries, killing the tissue. The downfall to that is that there's going to be a significant amount of inflammation. So it actually could cause the problem to get worse temporarily until that inflammation goes away and that tissue dies and becomes scarred, which then opens up that outflow tract area. The upside of that is we don't have to open heart surgery and go out and cut out a section of it. So it kind of depends on what the doctor is going to do, maybe what your facility is good at doing. Thinning of the septum and reduction of the flow and obstruction of and MR. So that's by going in and cutting that out, that's going to relieve that obstructive area. Right. And pacing might be occasionally used to kind of restructure some of the cardiomyopathies, depending on what's going on. And here is some pictures of that therapy. So here's the myectomy where they go in, they've got this blade and they're actually cutting out that chunk of tissue. Looks like a little device they've got in there to just retrieve it and pull it out. It looks like a tongue depressor. What do you think the problem is if you were to go in and try to cut this stuff out? What do you think you might run into if you're doing that surgery anatomically?
The electrical firings, wouldn't you mess that up?
Yeah. So you could certainly affect the electrical conduction system. So that could be a concern that we would have, as well as structurally speaking, just even the chordae tendineae are going through there. So if I'm putting a scalpel through there, you got to be careful of other structures around. We certainly don't want to be cutting off chordae tendineae because then we'll get flail leaflets on the mitral valve. And then this picture here is of them going in with that catheter. Now, I don't know exactly how this works, but it looks like they're coming in with the catheter. They're putting a balloon to block off the flow temporarily, while the end of that catheter ejects the ethanol out into that specific little branch, which then kills that area of tissue, which then opens up that flow through that area. We don't want the alcohol going back into other coronary arteries because then we're going to cause massive heart attacks, which we don't want to do. I don't know if they use radio frequency ablation, but I know in other vascular type of procedures, they do what's called the radio frequency ablation, which is similar idea. It goes into the artery or vessel or whatever it is, and it actually does radiation like X-ray, and damages the tissue, which then causes it to die and to collapse in on itself. I don't know if they do that in the heart, probably not, because they only ever mentioned this type. But alcohol ablations, that's what they're doing with this. They can also use alcohol ablations to stop things like different types of arrhythmias if there's something going wrong, some tissue that's irritating and causing the heart to uncontrollably contract. And that is hypertrophic cardiomyopathy. Any questions about that? We have one more section.
So Scott, on on my PowerPoint at least, I have like 8 more slides of this part 1.
Oh, you do? Let me see what I had there.
It goes into infective and restrictive cardiomyopathies.
Maybe those are on his next PowerPoint.
Yeah, I probably have them in the next ones.
Oh, they definitely are. Oh my gosh.
Yeah. It's like a textbook. Once in a while, we rearrange them. Yeah, so we'll cover that next time then.
Sweet.
Good, good.
Take a screenshot.
Screenshot of the sun.
No, it's just making a joke.
Yeah, a screenshot of the sun, Nancy.
Whose son? Kathleen. Julian.
Jet going behind
I don't know, Fez.
Fez.
Definitely like Fez.
All right. Well, on that note, then we will